obviously, Radium-223 has a very unique mechanism of action, which I'm not sure that we really understand. I think it's an alpha emitter, obviously, so it's a radionuclide-based approach, which is different to the all beta emitters. It's a short penetrance, it tackles the bone, specifically in areas where it has been bone remodeling. Again, as I alluded to you before, 80 to 90% of men with prostate cancer will develop bone metastases. I think the question that we have with Radium-223 is, number one, undoubtedly, the use of Radium-223 can make people live longer, right? Secondly, the problem with Radium-223 to some extent is Radium-223 doesn't have the impact of typical agents that we use in prostate cancer, meaning that only 16% of the patients on Radium-223 will have PSA declines. There is not a sense as to how often you should image patients, or for that matter, what is the impact of a radionuclide-based approach with regards to imaging. How do you define if a patient is benefiting on treatment when your PSA keeps going up, perhaps? So the reality of it is, when I think of Radium-223, mechanistically speaking, I tell my patients the goal of Radium-223 for you will likely be make you live longer, delaying the progression of your bone metastases, delaying what we call skeletal related events or skeletal symptomatic events, but we cannot define your efficacy on therapy based upon your PSA, which is the traditional marker that a lot of patients and physicians will pay attention to. So the ALSYMCA data, which is the phase 3 data that led to the FDA approval, at least in the United States, of Radium-223, actually used two different patient populations. They allow patients with metastatic castration-resistant prostate cancer with obviously predominance of bone metastases in the absence of visceral disease, which is a contraindication to some extent to give Radium-223. Patients who have minimal symptoms or have symptomatic disease from bone metastases, and those patients were randomized to receive either Radium-223 or placebo plus best supportive care at the time, or best standard of care. I think the important part is those patients actually were allowed to have received prior chemotherapy. So we have two pockets: some who have received prior chemotherapy and some who were chemotherapy naive. If you look at the data as a whole group, there was a benefit for all comers receiving Radium-223 compared to those men who did not get Radium-223. So you'll find two pockets of patients or two pockets of practice in the United States. Some people believe that Radium-223 should be given after chemotherapy. Some people believe that Radium-223 could be given before chemotherapy. I tend to believe that since you need at least 6 cycles of Radium-223 to really see that improvement in outcome, it is very hard for me to believe that a patient who has seen oral therapy, chemotherapy number 1, chemotherapy number 2, can go on to receive 6 months of Radium-223, an agent that to some extent may not have those direct benefits of PSA decline and a rapid improvement of symptomatic disease if one has symptomatic disease. So I tend to prefer Radium-223 a bit earlier. But again, as I alluded to you before, it totally depends on what sequence you have seen before, right? So if you have ADT chemo at front, then you may be able to get Radium-223 earlier. On the contrary, if you haven't seen chemotherapy and you saw oral therapy, it is possible that most patients will go from oral therapy to chemotherapy and then sequence Radium-223 at some time between first-line chemo, second-line chemo.